Thank you, Mr. Chimfwembe. Thanks to everyone for dialing in at this hour. I think the introductions have been made. Today, I'll talk about neonatal neurosonography. This is a very important tool, especially in neonates, because in every 10 live births, at least one birth is a premature. Without further ado, I would like to issue out a disclaimer that the images used in this presentation are not my images, and they were gotten from various sources, and that in the final slide, I've acknowledged them as sources and references. What do we expect? I think everyone should mute their mics. Thank you. So, what are our objectives? What do we expect to take home in this presentation? In this presentation, we are going to do a brief reminder of the anatomy. I know every one of us is quite familiar with the brain, but I would just like to go through it. The windows that we use in neonatal neurosonography, when we are doing cranial scans, what windows do we use? The techniques and the pathologies. Although in this presentation, I'll limit myself to intraventricular hemorrhages and their associated consequences. So, technique. What techniques do we expect to use? We expect to use a small footprint transducer like this one, because when you notice these babies, they are quite small, like this one here. So the anterior fontanelles, the windows that we use, they are small windows. In that light, we expect to use a transducer which is small enough to fit that space, because we are dependent on the spaces that are available to us. The other transducer we use is a linear transducer. This transducer is a high frequency transducer, usually 5 to 10 megahertz, and it's very, very high in resolution. So you'd want to use these techniques, these transducers, as you employ your techniques. Pretty much, what are the indications of this presentation? What are the indications for neonatal neurosonography? The most important indication, because what we deal with are infants, usually less than 32 weeks and 1,500 grams below. These are susceptible to bleeds in the space called the germinal matrix. The germinal matrix is a highly vascularized space hosted between the thalamus and the nucleus. Low Apgar score. An Apgar score usually is a score used by doctors to assess the health of newborns. It's done usually in the first minute and in the 5th minute. We look at the color and respiration, heart rate, and other things. Neurological changes also will warrant an intracranial scan. Cranial dysmorphisms like microcephaly will also warrant. Dysmorphisms just refers to the abnormal part of the body. So like microcephaly. Follow-up scans like hemorrhages that you usually see will warrant also, it's a qualification for as an indication. The benefits, what are the benefits of these scans? Well, it is safe. There is no radiation involved. Ultrasound is portable. These infants, statistics say that when you move them a lot, their conditions exaggerate, they become worse. So it becomes to their benefit when you follow them to the wards, to the NICU. It's reliable. Again, here, statistically speaking, we all know that ultrasound, the sensitivity ranges from 61 to 87, and the specificity from 81 to 97. So the reliability of it on producing reliable results is quite high. It's inexpensive as compared to CAT scans and MRI, and we can do a lot of serial imaging when we are following up the brain maturation and MRIs. Go to the next slide. Now, brief anatomy. I know that most of us are familiar with the brain and you're familiar with the anatomy. So I'm not going to do gross here. I'm just going to touch superficially and what you expect to see on ultrasound. The brain is divided into three main sections. The cerebrum, which is the most cephaloid portion of the brain here. We've got the cerebellum, also known as the hindbrain, and anything lower than this is called the brainstem, which includes the pons and the medulla. This brain, of course, it has ridges and grooves. This is why we are able to fit a small brain in a large brain in a small skull, in a small human skull, because of these. These are very important, these grooves and ridges on scan. You'll be able to see them as white echogenic, or should I say echogenic material, bending or meandering. I'll be able to demonstrate more on the coming slides. They are further divided. This cerebrum, the biggest part of the brain, is further divided into four sections: the anterior, the frontal, the posterior here in light green, the occipital, and there is the temporal and this other lobe called the parietal lobe. Separated here is a Sylvian fissure. We are also going to see it in how it appears on scan. The Sylvian fissure, very important anatomical landmark, especially those who would want to use Doppler on this. It's an anatomical landmark for the MCA, the mid-cerebral artery. This here, it's a central sulcus. Progressing. This is a very important landmark also. You look at the corpus callosum, the septum pellucidum. We all see these structures. The cerebrum, the fourth ventricle, you expect to see these. The pons and the medulla, you expect to see them. And again, we are coming back to these regions, very important in brain maturity. We'll be able to talk about that as in the later slides. Windows. What windows do you expect we use? The most important window is the anterior fontanelle window. Anything else, if you don't want, you can forget about this. You can forget about them, but this anterior fontanelle, you shouldn't forget about the anterior fontanelle. And my Zambian brothers and sisters would agree about this anterior fontanelle. We used to say that babies breathe from here. They don't. They don't breathe from here. It's just that by then when they are born, it doesn't completely fuse. And as sonographers, it becomes a very, very important structure to use. If you want to see in the posterior, you use the posterior fontanelle. This one is a supplementary view. The temporal window, also supplementary. These windows they will be further demonstrated why we should do them in further slides. In further slides, we'll be able to talk about these windows and what you expect to see when you're at that portion. Then the last slide is the mastoid view, especially when you want to look at the fourth ventricle in cases of posterior fossa cyst in Dandy Walker malformations. You'll be able to use these. Routine scanning. We should keep in mind that these scans that we are doing in neonates, specifically preterm neonates below 1,500 grams, below 28 weeks. So how do we go about them? Statistics say that these hemorrhages should happen in the first 96 hours. You should be able to see bleeds. This is in accordance with a study which was done by Dr. Volpi in 1986. They say within the 3 days, you should be able to see. So we usually expect to see one. We usually expect to do these scans in the first day, the third day, the 7th day, the 28th day. Then we do a follow-up scan monthly until discharge if things don't change. Otherwise, if they change, you are going to adhere to a neonatologist's requests. If they are less than 20, they are more than 28 weeks, but less than 32 weeks, you are going to do one in the first week and then monthly after that. You should be able to note that after 32 weeks, it's highly unlikely that you are going to incur intracranial hemorrhages, specifically intraventricular hemorrhages in full-grown infants, because as the infant progresses, the chances of them bleeding in the germinal matrix becomes less because they become stable. These infants, they become stable as gestation progresses. So it's purely clinical after 32 weeks. Standard views. So we do 5 coronal, 5 sagittal. If you want further studies of the mastoid fontanelle, you also look at the measurements of the transcerebral diameter. If you want to, there is published data on the transcerebral diameter corresponding to the gestation age. So usually these, they don't offer much clinical data. These images, the reason why we are doing these scans, it's because we want to see the neurological outcome, if there will be poor neurological outcome as the infant grows up or not. That's why we are doing these scans. In cases of white matter injury, you are expected to do a Doppler scan. If there is increase in intraventricular, if there is an increase in resistive index, then you will know that there is loss of photoregulations. You will know that the most likely there will be insult. There is insult to the periventricular white matter. The first image that you will see in sagittal. So what we are doing in sagittal is this. We'll get this transducer with this marker pointed the patient's front. When you're at 90 degrees, this marker here, this marker you're seeing here should point at 90 degrees to the patient's front. Then what do? You right or left. So this image, you are not sweeping anywhere. This is the standard view. When you just put there your transducer with a pointer pointing in front, you get this. The images that you will see are similar to this brain there. So this is the corpus callosum. Corpus callosum, this is what we are seeing here, the corpus callosum. It's not echogenic, but it's fairly echolucent or isoechoic to the adjacent, with the margins echogenic. Remember, there is a rule that you should always remember in ultrasound of the brain. White matter should always be white matter, and gray matter should always be gray. That is to say, the choroid plexus should be more white. It's not visible here. Should be somewhere there. We'll see in other slides. The choroid plexus should be whiter than the adjacent tissue. I shouldn't talk a lot here. So let's continue. The corpus callosum, the cavum septum is there. The cavum vague is there. The third ventricle, you expect to see it there. The aqueduct of Sylvius, which will go direct now into the fourth ventricle there. And this is the cerebrovenous, also known as the cerebellum. So up to there, you expect to see the cisterna magna. With labels, you see the corpus callosum, the cavum septum, and cavum vague. Here you see this structure here. This is not a cyst, but sometimes you have this structure in some infants. It is normal. It's called the cavum vague, cavum septum interpostium, cavum valium interpostium, sorry, cavum valium interpostium. It's a very, very normal system to see. We continue. So now, where you are at 90 degrees, you sweep now to the right. I usually go to the right because everything right is right. So I'll usually go to the right, turning my transducer. And the first image that you will see now, this is the most important image in ultrasound of the brain. The rest of the image, if you want, you can forget them, but not these images. This one, you will see the thalamus. In between, this is where most bleeds happen. This is the caudothalamic groove, thalamus and the caudate nucleus, in between caudothalamic groove. This white structure you are seeing there, this is the choroid plexus. The choroid plexus must be white. If you see this, this is the periventricular white matter. Choroid plexus is more white than this. If you see that the choroid plexus is as the intraventricular, the periventricular white matter is as white as the choroid plexus, you know it's a problem. That's one. Two, this choroid plexus you are seeing here, it ends here. Any white that you will see beyond this, it's a bleed. It's a bleed. There are no two ways about it. After that, you will go. If you see this, this is the same image, though in a more mature brain because of this sulcation. The thalamus, the caudate, and the caudothalamic groove, very important. Choroid plexus here. This is the glomus of the choroid plexus. We continue. The caudothalamic groove again, it will come into play. If you move from now, you were here, 1, 2. We take this one. This is the third one we are taking. So you are able to appreciate the lateral ventricle fully. If there are any bleeds here that you didn't pick on the previous image, you'll be able to pick. You'll be able to pick them here behind. That's the portion. So these images, if you have seen, I said 5 coronal, 5 sagittal. So 5 sagittal, there are 5. Don't be confused. So this is 1 at 90 degrees, 2 lateral either to the left or to the right. So you count 2, 3, 4. This is number 5. So these you have done. But if you want, others would go further, do what they call the chandelier view. If you remember, I talked about the Sylvian fissure. Others would want to demonstrate this Sylvian fissure in profile. It's not really important because you will get other important images. With me, it's just for sure. Coronal. So from where you were, the last image, you go back 90 degrees again, with your pointer pointing in front of the patient. Then you turn again to the right, perpendicular. Pointer pointing to the patient's right, 90 degrees. Then you push your transducer and further until as you can, not pushing, but rocking, bending it until you are able to see these orbits. When you see this, you start counting 1 because you see orbits, but your most important anatomical landmark you are seeing here is the interhemispheric fissure. Interhemispheric fissure under the periventricular white matter, frontal lobes there. 1, you count it. 2, you must see the cavum septum there. So 1, you see the interhemispheric fissure. 2, cavum septum. You see also the Sylvian fissure. Important. So the take-home point here is in yellow. The second one, you should see the cavum septum. The rest, secondary. Usually when you look at this, it's showing the lateral ventricles. These lateral ventricles, in some infants who have a fully matured brain, you won't be able to pick them. 3, you see the third ventricle, yellow, as we said, most important, yellow. The third ventricle, it will appear as a slit. Sagittal, it was appearing triangular. Here it will appear as a slit. You see the lateral ventricle. You see the corpus callosum there in the roof of the lateral ventricle. Then you see the choroid plexus. Choroid plexus should always be white. Rule of thumb. Choroid plexus should always be brighter than the adjacent white matter. 3, 4. You should demonstrate now these, the choroid plexus in profile. They should be, what I mean in profile, their full length should be demonstrated. Then periventricular white matter. Again, yellow, very important. So the last image that you see is the periventricular white matter. Very important, especially in the cases where you are answering a clinical question in which the neonatologist is asking about, is there HIE or not? Hypoxic ischemic encephalopathy. Is it there or not? This image is very key. So, a recap. The orbits interhemispheric fissure, 1, orbits in yellow, that's the most important landmark. 2, septum pellucidum. 3, third ventricle. 4, choroid profile. 5, posterior lobe. That's where you see now the adjacent white matter. Posterior fontanelle. You remember where you're coming at the posterior fontanelle. You're coming here. What you want to see is are there any bleeds that we missed on these other cuts that we are doing? So you will see that. It's also a good view if you want to compare the white matter to the choroid plexus. If you want to compare the choroid plexus to the white matter, rule of thumb, this should always be brighter than the adjacent tissue. These are other views that personally I find not important. This one will just remind you of the neutral scans that we do, where we are getting at the biparietal diameter. It's also very important to researchers if they want to see transcerebral diameter, the right and left hemispheres there. What's going on? Sylvian fissure, another important anatomical landmark. This is the temporal window, and this is the mastoid window. You are able to see the fourth ventricle. You're able to see the fourth ventricle there. Transcerebral diameter. It's used in dating, gestational dating. With me, it's not really important to see from there. You can use the gyration and sulcation, the grooves. Doppler. Others here, they prefer to use the mid-cerebral artery. I prefer the anterior cerebral artery. When you just put the transducer, when you're doing sagittal, look at that image. This one. You rock a bit, then you would have found your anterior cerebral artery. Reason being in alloprosencephaly, that's where you have a monoventricle. This is a snake under the skull sign. It will cause, instead of causing here and in front of the corpus callosum, it will cause going to the skull. This is why I prefer it. It's easier, and it can show a lot of, it can show in cases of alloprosencephaly, it's used, but we are not talking about alloprosencephaly here, we're talking about Doppler. Doppler, it's usually used in intracranial ultrasound where you suspect an insult. When you get your caser, you put here, you expect to see this waveform. This is a normal waveform. When you trace your peak velocity, peak systolic velocity to end diastolic velocity, it should give you between 0.6 and 0.8 with a standard deviation, that's plus or minus 0.05 again. What happens if there is an insult? If there is an insult, it means that there is loss of cerebral autoregulation. You expect this diastolic to rise because there is nothing anymore to regulate blood flow. It will give you a clue that there is an injury. Remember, these look like this. I was stressed. These look like this. So sometimes normal color Doppler won't show anything. That is why now you will go to power Doppler. The trade-off here is that it won't show you the direction of blood flow, but it will pick these blood vessels very, very clearly, as it is notorious to picking blood vessels with low blood flow. Brain development will look at the gyration, gyro development, that is gyration. So in features where it is in an infant where it is 24 weeks or less, it's discontinuous, then the gapping is wide, the insular, between the insular and the posterior, the occipital fissures. So between 28 and 32 weeks, you expect primary branching. 36 weeks, you expect secondary branching. 38 weeks, you expect tertiary branching. What the method that I use is this. This is the singular sulcus. This infant is 24 weeks or less, like I said in previous notes. When you start seeing this singular sulcus continuous, you know that the infant is above 28 weeks. Corpus callosum, cavum septum. This is the singular sulcus. It has primary branching there, if you see it. Then in full term, you expect this. A lot of branching. This is a singular sulcus here. It has branched a lot. This is how you know that the infant is full term. Some people use the cavum vague, though it's not reliable, as it has shown in some infants to persist even in adulthood and mid-adolescence. Geminomatrix hemorrhage, sometimes called subependymal hemorrhage or intraventricular hemorrhage. I don't like this term, intraventricular hemorrhage, as I'll demonstrate, but neonatologists love it because it provides quantitative grading for neurological injury. That is 1, 2, 3. It's very clear. It's approximated that these premature neonates experience geminomatrix hemorrhage, at least 50% of them. This is the most common neurological complication with them, and some stats puts it as high as 20 to 25% without showing any symptoms. The symptoms that they use sometimes is to feel the anterior fontanelle if it's full, anemia, and in more rare cases, seizures, change in uncontrolled muscle contractility. So the bleeding, as we said, it happens between the caudate nucleus and the thalamus. They got the geminomatrix, the caudothalamic groove, which hosts the geminomatrix. It happens because of loss of autoregulation system. And as we said, from 1980, in the 1986 research by Dr. Volpe, by 96 hours, this should have occurred. Subependymal hemorrhage or intraventricular hemorrhage. And 80% of these cases will become worse. It will progress to either grade 1, 2, 3, or 4. From grade 1 to grade 2 or 3 or 4. Grading system. I don't really like it again, but widely used. It is very used. I don't like it. Why? Here is the reason why. I'll come back to this slide, but this slide be explained here. This is the lateral ventricle. These are lateral ventricles. This is the geminal matrix, normal brain. This is the subependymal hemorrhage. They are calling it grade 1 intraventricular hemorrhage. This does not break the barrier of the lateral ventricle. So this bleed is happening outside the lateral ventricle, but still it has been given the name intraventricular hemorrhage. That's one reason I don't like this grading system, but very widely used. When you come to grade 2, nothing wrong. So grade 1, remember, it will be subependymal because it doesn't break into the ventricle. Grade 2, however, will break into the ventricle, but it won't cause the dilatation of the lateral ventricle. So the difference between grade 2 and 3 is that these two, they'll break barriers. This one will not cause dilatation of the lateral ventricle. This one will cause dilatation of the lateral ventricle. That is the difference between 1 and 2. 2 and 3. Grade 4. Again, this does not occur in the lateral ventricle. It was known back then that it occurs intracerebral, then it goes into the lateral ventricle to dilate it. But now it is thought that it's the grade 3 intraventricular hemorrhage, which progresses, which causes, remember, because it's causing the lateral dilatation, it will cause compression of the adjacent blood vessels, and then it will cause ischemia. This is why I don't like this grading system. It's accurate, of course, and it provides, it's a very good tool in monitoring the neurological outcome. But because of 1 and 2, they are, that is why I don't like it, but very good too. So this slide is what I was explaining here. So what do you see on ultrasound? This is what you see. Normal. Nothing wrong with that here, with this brain. Here you see subependymal. It doesn't break into the lateral ventricles. It is just adjacent to that there. In sagittal, you see it more clearly there. This is white than the choroid plexus, bleed. You go there. No, but so you go there. But you go there. The grade 2. It has broken the barrier and has caused dilatation. It has not caused any dilatation, as you can see. These ventricles are perfectly fine. It's well seen there. And here you can see that the importance of taking images in 2 planes. Because sometimes you can't really appreciate something, but when you take it in you will see clearly. Grade 3, dilatation of lateral ventricles. Where is the bleed? Because here we don't see it. You can see it there, but you can't really appreciate it. But there you will see the bleed clearly. And grade 4, as we were saying, it has gone there, broken the barrier, and it is there. The consequences of intraventricular hemorrhage, hydrocephalus. grade 2 germinal matrix hemorrhage, and grade 3, they are usually mistaken because sometimes you can have a complication in like hydrocephalus. You can have intraventricular hemorrhage with secondary hydrocephalus. This one will occur when the arachnoid villi are impaired because of the blood involved. They will be impaired in the absorption of the cerebral fluid, or there will be a block somewhere here, just above the fourth ventricle, this aqueduct of Sylvius. That's a common area for that block. You can use Doppler to see increased intracranial pressure in hydrocephalus. You expect this wave to be opposite. This that you are seeing here, if there is increased intracranial hemorrhage, there will be reverse flow. So they will be down there. That's how come you know that there is increased intracranial pressure. The other consequence for IVH, intraventricular hemorrhage, is HIE, hypoxic ischemic encephalopathy. This is an injury or an insult to the white matter of the brain. It's estimated that 2 to 4 live births will have some form of ischemic encephalopathy. Usually, since the brain is the most important part, is counted by the body as the most important organ, this will lead to multiple organ failure because there will be shunting of blood to this brain. So the first sonogram that you will do will be normal in HIE, but follow-ups will show echogenic lesion leading to this periventricular leukomalacia. So just the images there. This is what you expect to see with injury. This is the first one. These are different cases. You expect to see that. White matter should always be white. Gray matter, gray. Look at that. It's indicative of an insult. Look at that. Periventricular leukomalacia should be the last consequence that we'll talk about. Periventricular leukomalacia simply means peri adjacent to the ventricles, peri-adjacent to the ventricles, periventricular, then leukomalacia. Leuko, it's white matter. There are leukocytes in the body. So leuko, white matter. So this is the cavitations and cystic formation in the periventricular zone. As a result of which one? HIE. So these changes will occur after 6 weeks usually, but in between 2 and 6 weeks, you should be able to see something. There will be significant impairment of the motor actions that will follow. So there are grades as well. Usually this first one, you won't see anything, but here there's something. As you progress, you'll be able to notice that these cavitations are increasing, and these infants are usually associated with poor neurological outcome, and they have difficulties in grasping simple milestones like walking and other motor functions. So grade 1, just increased echogenicity in the periventricular zone. Then grade 2, you'll be able to see some, not a lot, some cysts beginning to form. Grade 3, a lot of cavitations forming, and grade 4, gross cavitation forming in the periventricular zone. Sagittal will also demonstrate that, very key in taking images, images in 2 planes like that. There are limitations to ultrasound though. The examination does not view all parts of the brain. In cases where you have infants with small anterior fontanelles, it will be very difficult for you to see because you'll be seeing black in between, black adjacent to that. Movements, these guys move a lot. Then some fontanelles will close. Limitations. So what is the take home? Neonatal neurosonography is reliable tool, especially in preterm. It does not view everything, but it's a pretty much used tool. It's a widely used tool. It will grade all hemorrhages and make sure always you take images in 2 planes, and ultrasound does not answer all the questions. I thank you everyone for listening. I rest my case.